82% of trainees would recommend their region to other people.
But amongst trainees, we feel aesthetic training is not where it needs to be.
Massive hit of the TIG fellowships growing.
Absolutely, we need to reduce any form of harassment with them. But I think the most worrying thing is about reporting.
Trainees and trainers go for a coffee together, develop closer relationships that lead to better training and to better consultants of tomorrow.
At the beginning of every day, you define exactly what each individual wants to get from that day and make every interaction a positive one between trainer and trainee.
Great, welcome to another episode of The Rest is Plastics for JPRAS. So thanks very much for tuning in. Today we'll be discussing plastic surgery training in the UK and Ireland. Our conversation is based on the National Training Survey conducted by Plaster UK and recently published in the JPRAS. Now, for our international listeners, Plaster UK is the National Plastic Surgery Trainees Association. And this survey provides valuable insight into what it's like to be a plastic surgery trainee in the UK today, including perspectives on training opportunities, workforce challenges, and the evolving training environment. Joining us today is a panel of 4 guests, 2 trainees who co-authored the original survey paper and 2 senior plastic surgeons who co-authored a response to this article. So to begin, perhaps we can go around the panel and ask each of you to briefly introduce yourselves to our listeners. Richard, can we start with you?
My name is Richard Clough. I'm the president of Plaster UK this year. I'm a Northwest plastic surgery trainee and I'm currently a research fellow down in London.
Susie.
Hi, I'm the immediate president for Plaster, and I'm a SPR or resident in plastic surgery in Dublin.
Great. Chris.
Hi, I'm Mr. Chris Duff. I'm a consultant plastic surgeon in Manchester, England, and I sit as the vice chair of the SAC, the Specialist Advisory Committee.
And finally, Nick.
Hi, my name is Nick. I'm a plastic surgeon in South Wales and I'm currently the chair of the SAC.
Well, welcome everybody to the podcast. It's really exciting to have you all here, and thanks so much for making the time to speak with us. I'll start by asking the trainees the first question about their paper. Perhaps Susie or Richard, one of you can tell us, what was the aim of this study?
So thanks a lot for having us on the show, James and Anton, and for helping us stimulate discourse around the paper. As you've explained, Plaster represent plastic surgery trainees, and plastic surgery training in the UK is split up into different levels. So there's, at the most junior level, there's core surgical trainees who rotate through lots of different areas of surgery. And then following on from that, our equivalent of residency is known as being a registrar. It's that group of trainees that this survey was aimed at. So people on our equivalent of a formal residency programme, and people who have national training numbers. We had 2 main aims from the survey. We've run the survey for the past few years, I think since 2020. Our main aims are to identify key issues that are topical in plastic surgery and to try to stimulate discussion around them, and then to benchmark progress and compare the results to previous years and to see what direction everything's going in.
Susie, perhaps you can describe for us, what was the methodology that you employed in the paper?
So put simply, we have our monthly newsletter and weekly webinar emails that go out, and we have a really collegiate group within Plaster. So we send out quite a lot of information. Once a year we do this survey, and last year we wanted to do it earlier in the year so we could enact on, take action on the results we had. So as an executive group of Plaster members, so there's 17 of us on the executive committee, all nationally appointed throughout the whole of the UK and Ireland. We came up with 81 set questions with different themes that we really wanted to get feedback on from nationally appointed trainees. So trainees who have got onto our residency scheme, and we essentially sent out that survey to everyone, and we had a set time frame for that. And we'd validated all of the questions with our executive committee, our regional members, and then got all of that results back and went through it painstakingly over months to get our results together and formulate our paper. So essentially that was the whole bulk of our research.
I guess one of the first things of any questionnaire-based study is the response rate. And there are sort of biases that can creep in and around that. What was your response rate, and how do you think that corresponds to the results that you got?
We had 142 responses from plastic surgery trainees. As Susie says, we validated them all. We cross-referenced them to make sure that everyone was on the training programme. By our estimate, there's around 380 or in that region of trainees nationally. So that puts it at around a 42-43% response rate. So it's a cross-section. It's not every single plastic surgery trainee in the country. There was a fairly even split between men and women, but there was a skew towards the earlier years of training. A lot more ST3s answering than there were ST8s. We feel that we are representative. Of course, it would be nice to have a greater number of responses. And when we repeat the survey this year, we'll be trying to use the momentum that we've gained to push things forward and aim for even 70% of responses. One of the kind of arguments that could be made, or one of the things that sometimes I hear, is that it's potentially a self-selecting group of trainees who choose to answer surveys like this. Maybe it's people who aren't having such a good time, or people who want to raise concerns more, or have more of a negative take on things. What I would say in response to that is that actually, when we asked trainees about their satisfaction with their training, 82% of trainees said that they would recommend their region to other people. So that's broadly positive. And when you compare that to the statistics from the GMC's National Training Survey, which surveys every single doctor in the country, or aims to, and they have a response rate of about 70%. Actually, their similar kind of satisfaction level falls at around 84%. So 84, 82, I'd say you've got a similar kind of level of satisfaction in the trainees who've answered this survey. There's probably other things that we can talk about in the way that the survey was distributed too, if you'd like to.
Yeah, I'm sure that's right, and there's probably a way statistically of telling if that number 82 is different to 84, isn't there? But perhaps a question for another time. I mean that leapt out at me immediately, that an overwhelming majority of people are satisfied with their training and recommend their deanery. So I thought, a really sort of good news story. What else, or what other main takeaways do you think there were from the paper?
One of our key takeaways was our training within the aesthetic surgery. So we're being trained in plastics, reconstructive and aesthetic surgery, but amongst trainees we feel, as proven by our survey, that aesthetic training is probably not where it needs to be, with over the majority of trainees not getting trained out with the NHS in aesthetics. And we feel that they are probably getting most of their numbers within, say, doing a DIAP-free flap and counting that as an abdominoplasty, for example. So, that's one of the key points we want to take away, because there are a few really great deaneries that host rotations within aesthetic training, so 3 months at a time, going off and trying to get some experience within that domain of plastic surgery. And as a group, we feel this is a really good model that we could potentially put out to all deaneries to utilise. And that, for us, is definitely one of our hot points of something we can improve upon as a group of trainees and trainers.
I wonder if I can jump in here, Anton, because for listeners who haven't read the paper yet, I think it'll be quite useful just to summarise what the main results were in terms of the trainees' subspecialty aspirations, the training provisions and indicative numbers and so on. Perhaps you can quickly summarize that for us.
In terms of the key kind of findings, so we asked trainees about what their subspecialty aspirations were. and we asked for their number one and their top three. Broadly, the two far and away most popular were hand and upper limb surgery, I think was number one, and then breast microsurgical reconstruction was the second. Broadly representative of what a lot of training programs consist of, and a lot of the work done by plastic surgeons has shifted in these directions in the UK. The third on the list was head and neck surgery and head and neck reconstruction, and then there was a relatively even split between all of the remainder of the subspecialties after that. We asked about key metrics related to training. So we asked, and we discovered that there was quite high rates of heterogeneity in the way that training is delivered. So that tallies with data from the 2021 study, the last time that we published our national training survey. But particularly, as Susie says, with regards to aesthetic surgical training, in some deaneries, trainees are given formal aesthetic rotations. In others, they're going into clinics on their days off to obtain this experience. In another key area was the opportunity to undertake fellowships during training. So the vast majority of trainees, I think almost all trainees, said that they thought undertaking a fellowship before they finished training would be useful to them. And as part of the JCST's recommendations, the latter years of surgical training are meant to be focusing on developing areas of subspecialism. So fellowships would be well suited to this. However, I think only 50% of trainees actually reported that by their knowledge, they were able to undertake fellowships during training. And in at least 20 or 30%, they believed that they weren't, and that they'd have to wait until they finished training. It was really broad survey. So we discussed lots and lots of other things too. I'm just trying to think of what the key ones to highlight.
I think another important aspect of the survey was the well-being, bullying and harassment section. I think this really speaks for not just trainees, but I'm sure trainers also have this within their own workplace as well. 22% of trainees felt unsupported, and 28 experienced stress or anxiety, with a third reporting feeling burnt out. And I think that's something we probably at one point have probably felt within training, and even maybe as a trainer. With almost a third reporting feeling a lack of autonomy as well within their practice. So I think some of the results within that section were quite stark, because with different organisations trying to help stamp out bullying and harassment, I think it's still an ongoing theme, and it's something that we really want to try with the help of, say, JPRAS, to try and tackle this and keep this going as an ongoing situation to stamp out again and keep stamping it out.
Yeah, I mean that did leap out to me, reading the paper, and I wonder, was there any common themes or any more granularity, or was that as much as, was it the experience of bullying, or was there any suggestion of what any typical flashpoints might be, or this is something we should look into separately?
So we did collect that data. It was a really broad study, and there was unfortunately too much for us to be able to delve into that deeply. But actually, we're in the process of writing a letter to JPRAS with more of a deep dive into that side of things. But when it came to bullying and harassment, we asked trainees about the ways in which they were experiencing it. And who the perpetrators were. Actually, broadly, the perpetrators were a wide range of different sources. So it wasn't just consultants. I think consultants made up about a third, but then some of it was coming from other trainees, and some of it was coming from various different healthcare professionals. We asked them about barriers to reporting, and the most common kind of themes that they came back to us with were a fear of not being taken seriously, and fears over future career progression and impact on their career in the future. I think out of the third of trainees that responded to us saying that they'd been bullied during their training, I think less than a sixth said that they had reported it. So we want to work with JPRAS this year, and we are doing currently, to try and take steps towards encouraging more reporting, and to make trainees feel like it can be taken seriously.
Well, thanks very much for raising this issue. Obviously, a very important one, and I think we'll have to come back to that in a bit. But I wonder at this point, can we bring in Chris and Nick? Because when you read this paper, what jumped out at you? Did any of these findings surprise you? What did you think?
I find that much as you've reflected, Anton, there, I do find these reports of bullying and harassment worrying, and that was one of the key issues that I recognised. The survey really reflects the discussions we have in the SAC meetings, which aims to address training issues across the patch. And one of the major ones that does get highlighted is aesthetic training, and the geographical element of that and the changes across the region. And when I've looked down into it, it becomes clear why these sort of problems exist. In terms of the geography of aesthetic training, it usually comes down to money and time, and that's something that I think we spend quite a lot of time discussing in the SAC. In addition to the sort of the survey, we've had this sort of massive hit of the TIG fellowships going, and just for the international audience, training interface groups have been running fellowships for senior trainees just before the completion of training for a year. And those training interface groups cover things where plastic surgeons commonly work with other specialties, and breast reconstruction and oncoplastic surgery, hand surgery with orthopedic surgeons, cleft lip and palate surgery with maxillofacial surgeons, and so on, as you can see in the paper. The funding has been withdrawn for those fellowships, and that has a massive impact on the senior trainees and is a source of constant anxiety to me, and the desire to return to that format is something that I fret about quite regularly without having the power or the money as an SAC to be able to influence perhaps that decision that's been made at governmental level and the Department of Health. So we are in a slightly backs against the wall situation for certain amounts of these things, but bullying and harassment is very much down to individuals and colleagues. And the fact that it is such a problem still, and any of it is a problem as far as I'm concerned, and stamping it out, as you say, Susie, is very important. I think we are beholden to address that as a profession and as a group of trainers, to try and see what the detail is from you, Richard, to help us to work on that. And I'm grateful for the detail, really, actually. Thank you.
Yeah, I mean, I'd like to come back. I think absolutely we need to reduce any form of harassment and bullying within any area we live in and work in. But I think the most worrying thing is about reporting. So because yes, you can hopefully reduce a significant amount of it, but it won't. It can, in every environment, it is going to be present. It's about it being reported and acted upon. And I think that's something I think we need to work together with Plaster to try and achieve, is to increase the reporting rates, because it's from there that actually action can happen, and we get a true idea, because I suspect it's a minute amount in compared to the reality, which is very sad. So I think we can, as an SAC, obviously we can't action on, because that is not our role, and in fact not the role of JPRAS, but we can be the voice to make sure that we get to the right places. And I think that was one of the things I hoped I got back when Chris and I wrote the commentary on the paper, which is a fantastic paper by you guys, was just to try and show the complexity of where the SAC sits within the training. We don't hold any funding, but are required to take full responsibility for how it goes, because the funding is obviously coming from the Department of Health via the deans, via COPMed. So I think that's one of the complexities about British training that I think are difficult to understand, and difficult because, as an SEC, we're very much your voice at higher echelons in training rather than the other way around. But I thought my general thoughts are that things were at least satisfactory. 80% recommend the training. I think it's a really encouraging thing. I think that's a good thing. But that is at no point, therefore, should rest on laurels, because training can always be made better. I thought with the aesthetics section, it is a little bit improved from the 2021 survey. There's a little bit more access, and I agree that there is something. And we have already spoken to the dean who sits within COPMED, which is for everyone else, COPMED is the group of deans that really have control over the different deaneries within the training in the UK, to highlight this area, because it is a very significant worry to me that we are not, that is an important element of training which might be being missed. But I think one of the really standout bits, which we haven't mentioned, if I'm happy to talk about, was that 75% of trainees were in favour of medical associate professionals being involved in the team in plastic surgery. Now, I am an outsider within JPRAS Council, that's the British Association of Plastic Surgery Council in the UK, in a belief that I think they can reduce the administrative burden on a junior doctor or on a resident, so that they can involve themselves more in training. But I'm very much an outsider on my belief, particularly within higher echelons of plastic surgery training. But it was very interesting, that point. I thought those that actually work with medical associate professionals actually realizing that they might have a benefit to them and to training. But it might be reference to the fact that it's a relatively junior cohort in the training program. But I'd be keen to know what Susie and Richard thought on that, because I thought that really stood out, that 3/4 of trainees thought that was a benefit. Yet in the council, I'm probably the only one that speaks positively about that.
I agree with you on that. So I'll come back to that point in a second. But when we ask trainees about the number one thing that impacts their training, all of the things were training quality related. Service provision was number one, lack of training opportunities was number two, and closeness in relationships to consultants and consultant willingness to teach was the third one. If we want less service provision, if we want to spend more time doing training activities, things that are useful to our future careers and our future patients, then someone needs to do the other activities. They're not going to go away by themselves. I think that medical associate professionals have been recommended previously, I think as part of improving surgical training. The report from 2019, a large part of that was recommending increasing their implementation so that they can take away more of the service related tasks, so that trainees can focus more on training and spending more time with their consultants, and obtaining supervised autonomy, working alongside directly with their consultants. So I'm positive about them, and I agree with you. The results from trainees were positive about them too, but in a non-operating context. So as you say, 75% were in favour, but only 20% of them were in favour of medical associate professionals having any kind of operating role.
Related to this, of course, is the idea of indicative numbers and trainees having the opportunity to be involved in these operations. And one of the things that is often talked about is whether the indicative numbers reflect the current work that's needed for our generation of plastic surgeons. Maybe Susie and Richard, can you just talk to us about those findings, and maybe we can get Chris to comment.
Yeah. So within indicative numbers, so in the UK and Ireland, our indicative numbers we have to meet by the time we want to complete training. So for example, we need 30 zone 1 or 2 flexor repairs, for example. That's one of them, or 27 free flaps. And these have to be ones that we have done and not just, assisted in. So whenever we did the survey, we wanted to see if our fellow trainees were struggling to get these numbers, and 57% are struggling to get their lymph node dissections. But that's in keeping with the current sort of practice that, compared to 10 years ago, we're probably not doing as many axillary or growing clearances. and people are struggling to get them. However, we are doing a lot of sentinel lymph node biopsies, and that's probably reflected across the UK and Ireland. Interestingly, Dupuytren's contracture, 42% find it difficult to get our Dupuytren's numbers. So we need at least 24 indicative numbers within the Dupuytren's area. So I found that really interesting to come out of the survey. Maybe I've just been in hospitals where we do loads, but I thought that was really interesting. And then, of course, aesthetic numbers, 40% are finding it difficult to get their aesthetic numbers. Now, the interesting thing about aesthetic and cleft indicative numbers, we only have to be assistants. So we don't necessarily have to perform the case, but we can at least assist in the case to have those count within our indicative number section. But yeah, I thought that was quite interesting because it's good to see where we're all at and if we all, feel the same way about getting our indicative numbers.
Out of interest, Anton, how do indicative numbers work over there in the States, and are they set up in a similar way to ours?
Yeah, very similar. I couldn't tell you what the numbers were. I'm not the program director, but yeah, our trainees have to have the same system when it comes to indicative numbers, and I mean ours never have a problem getting them. I couldn't tell you what the balance is in terms of. But then they do 6 months of cleft craniofacial each, and they do 6 months of aesthetics each, and they have their own aesthetic clinic. The chief residents here. We also have 4 PAs for the 6 residents as our part of our staffing ratio, and they do once the residents have handed off in the morning, they go to the OR and the PAs do the ward work. So.
And is there positivity from the residents towards the PAs and the medical associate professionals?
But yeah, super high positivity. They work hand in glove, and they don't mind. And it's not about them not operating. I mean, it's, to be honest, when if we want donor site. I mean, one of the PAs closed my donor site this morning. That's how. And while the resident was in setting the flap, that's how they work, and that's fantastic. And we don't really have enough residents for all the faculty here, so the PAs have to step into the OR sometimes to help assist the faculties that don't have a resident. So that's how we work it here. But we have the same tension with the aesthetic. I mean, they do get a lot of aesthetic exposure, but that's an international issue. If plastic surgeons are going to keep ownership of aesthetic surgery, then which all of us want, or at least when I go to the meetings, it seems what people want. We're going to have to train the trainees in it. Or that's going to be, or someone else is going to take the lead of that arena. Whether or not we ourselves are hugely aesthetic in our practices. So that was I did find that.
I'm even more concerned from an aesthetic point of view because I think there's 2 big sort of areas within aesthetic. There's clear, very precise aesthetic surgery, rhinoplasty, non-functional rhinoplasty, facelift surgery. But there's a huge amount of what is regarded as aesthetic surgery that was a commonplace part of plastic surgery training in mine and Chris's era, in that, massive weight loss surgery, breast symmetrization, pinoplasty, things that I would regard as actually standard, plastic surgery procedures. A pinoplasty, there are a lot of trainees that don't come through training that can't actually do a pinoplasty, which that not too long ago was a senior SHO operation and now seems to be a consultant operation. And it worries me. But it goes back to the point when it comes to indicative numbers, and something I've put back to Susie and I will put back to Richard is not how hard it is to get numbers, is how many numbers do we need to demonstrate capability. So that's the key element. It's not, well, it's impossible to get 10x and therefore we'll look to try and get 8x. It's how many numbers do we need? And that was why the new curriculum came in 21, was to show not only numbers, but also 3 times you've demonstrated that you can perform that procedure in front of a consultant and him or her sign that off as appropriate. But this is the difficulty we've got, is that goes back to Anton's point, is if lymph node dissection, if we reduce those numbers or put that into a specialist area after training, you can bet your bottom dollar there are other specialties that are going to jump in on to lymph node dissection. And my sort of desire as an SEC chair is to keep plastic surgery that wonderful broad specialty that I came into, where you can do hand surgery, breast surgery, cancer surgery, and head and neck. And so I am worried about some of the moves away to sort of subspecialize, whether the oncological side of surgery, because we won't end up becoming a broad consultant at the end of training. But I do agree we need to be putting pressures on the training regions to make sure they find innovative ways of getting that. And I do, and one of my views is that I think sometimes that might be people moving around to higher volume areas to get some interest and to get some experience, because I think that cross fertilization between regions is really key. It's how you meet new consultants. It's how you look for jobs in different regions. It's how we learn from each other. And that's as consultants as well as trainees. There's nothing more stressful than having a consultant come to watch you do something when you've been working on your own for 20 years. I can tell you that for a starting point. But I do think some changes that might come forward in the next few years is that cleft was brought in as a specific number to try and protect cleft surgery within plastic surgery, to give people, make sure that they had that experience so that it was maintained within the plastic surgery arena. But I'm, as a pediatric plastic surgeon, primarily, am keen that there are other areas within pediatric plastic surgery which are incorporated into that group, whether that be hypospadias, congenital hands, brachial plexus, spina bifida, oncology, all those things that actually would demonstrate a broad experience in pediatric surgery. So I think, we need to sort of address where the difficulties are, but what we're required to show competence. I think that is the key element for me.
I think some of the elements of it do reflect a change in practice. So lymph node surgery is completely changed in the context of immunotherapies in the management of, say, melanoma, which is where most of the oncology comes from in lymph node dissection, certainly. I think there is merit in having a target, because people then seek out that target and gain experience. Yes, okay, you don't need to have operated on 30 clefts, but having seen the precision with which one has to operate and the tissue handling techniques in a cleft surgery, you gain benefit from that element of observation, which you can then take forwards. And simply observing someone doing something. If I observe an operation, you and I, James, would see two different operations because of your experience prior to now and mine. And I would take away, a little technique, and you'd take away a different technique. But we'd both benefit from watching an experienced colleague operate. And so the sort of observation element, Susie, I think it does have value. And I think in aesthetic surgery, it's difficult to say that you charge into the private sector and say, all right, I'm doing the next 3 facelifts because I need to do them. But there have been models in the past where reduced price surgery has been a way of offering aesthetic training. Something that has come up is whether do the government have to train trainees in UK plastic surgery in aesthetic surgery? Because it's not something that they have necessarily want to pay for. But I would argue straight back and say, well, we spend our whole time managing the complications of plastic surgery from people who've travelled and people who've had surgery in the UK, where the on-call system doesn't necessarily cover that individual. And the complexities of that surgery that may have been performed by someone else is important to understand. So I think it is very important we push for aesthetic numbers, whether it's in the current format or with a revised format, which I would like to see, so that you do get a formal aesthetic rotation in each deanery. But that I know is difficult, as I said earlier.
I'm in absolute agreement. I think that there's absolutely no way that we aren't continuing to push that. It's a recurring agenda item on every SAC meeting, and specifically we brought in someone from BARPS to sort of make sure there's better connections with SAC BARPS, and BARPS is the aesthetic element of the British Association of Aesthetic Plastic Surgeons. But it's absolutely key that we continue training as broadly as possible, because I think otherwise we're not. The consultant learning curve is scary enough. I can let everyone at the beginning. It's going to be even more scary if we start finishing without the broadest training possible, and that would be a significant concern.
What's really interesting is that in the UK, we already probably have the longest training in the world compared to many of our peers in Europe and in the States. And one wonders, how we can streamline training so that it doesn't go on forever. Thoughts, Anton, from across the pond?
Yeah. I mean, our residency is 3 years. Now, they've already done 5 years of general surgery. But there's definitely a different, there's definitely a different products. I noticed that the 10% want to go into the private sector. Well, 50% of ours go straight into the private sector. But if those go into academics, they will all do a fellowship. There's no, we've never appointed a consultant that hasn't done a fellowship from following an American residency. So these sorts of differences. I was just wondering, casting my own mind back, when I was a trainee in Bristol, we had an aesthetic fellowship that was part of our training rotation. I can't remember. It was something to do with our education, giving up half an education day between us, and that generated a 2-month block or something. But Susie, you mentioned there was the system that some deaneries have and models that have been successful. Can you describe those in any more detail?
Yes, so the Macindoe Centre in East Grinstead and in Manchester Northwest Deanery, they have 3 months where the trainee is, I think, still part of the rota to be on call, but essentially they're not on the rota and they go off and go into these aesthetic hospitals. So I think that's really great to just be able to have time to go and be mentored by someone, see facelifts, get your hands on experience with rhinoplasties, and just have that solid 3 months of learning. 3 months out of 6 years is not a lot. And I think it's key as part of our reconstructive practice to have that, short amount of time in the aesthetics world.
How is that funded then? So they still take call, so that must cover some of it. How is the rest of it funded? Do we know?
I can probably comment on that. I think the units where they do have a formal, it's part of their training program. So Wales has one. They have one. There's about 4, I think, formal ones, aren't there, Susie, around the UK? But it's just part of that. They leave the program for a certain period of time. I know in Wales, for instance, they have a cleft aesthetic. So if you're very much into cleft and you're not particularly into aesthetic, you will spend more time in your cleft part of that block and less time in the aesthetic. But it gives you opportunities to expand that sort of subspecialty areas. But yeah, it requires the deans of the head of each deanery to approve that. And that's the area we need to push. So and that's what SEC are trying to do, is to put pressure on those deans to make sure they're delivering the curriculum which is written and clearly demonstrates that they have to have training in that area. They can't move away from that. Now we are due to rewrite the curriculum, and we are in the process of concreting that even further within the curriculum. To ensure that it's there and is not questioned. But I do think it's an issue, and I think we have to put pressure. Can I go back to the fellowship element? I think Richard mentioned a bit about fellowships pre-training. So it felt like, I think quite a lot of the trainees were relatively junior that responded, but obviously OOPT, or out of program training experience fellowship, is fully supported. It is in the Golder Guide, and it's fully supported by SEC. And the recent survey of all the TPDs was that it can be done in the final year of training. And if you find issues where it can't be, that's when it should be individually reported to myself and Chris, so that we can take that back up with each individual training area. Because all the responses from the TPDs was that it may be more difficult, but it is definitely allowed to do training in the out of program training in the last few years of training. So it would be interesting if the Plaster membership aren't experiencing that, then there's a disconnect, and then we will be your connect to the TPDs, if you know what I mean.
No, thank you very much for clarifying that with the TPDs.
Is there anything that anybody that thinks we haven't covered that we should have covered based on this paper? I think we've gone over a lot of it.
If you wanted some clarification on funding, I can highlight the difference between different areas that have actually fallen within my SAC experience. So the funding for the Manchester Aesthetic Fellowship is generated by us having a lead employer organisation, LEO, and that's one of the trusts in the region, supported by the deanery, to employ all the trainees in the region. So it's a massive funding organisation, but it does mean that the trainees don't get paid by individual hospitals and don't have to change their employer each time they move to a new trust, which is a massive difference. If you need to find money for an aesthetic training programme for 3 months in 6 years, it's much easier to ask the LEO than it is to ask an individual trust to give up their trainee, and they may have a limited number of them, and say, right, not only are you going to have to pay them, you're also going to have to lose them for 3 months. So that's one of the major problems that we've identified, and there's no sort of national move to change that to LEOs.
No, and I think it's probably how we benefit in without my SSE hat, but with my Wales hat on. That's how we probably, because we have a lead. It's not, you're not employed by the trust; you're employed by a single individual group. Again, so that is a benefit. I think that helps us. But
so the trainees listening, the take home is apply to Wales or Manchester.
But I'm happy to comment just on UK training. I'm in agreement. I think it is longer than average. But of course, the length of the training is only the standard. So training can definitely be made quicker with certain trainees, but it does require that to be identified early on in the training program. Okay, it cannot be done towards the end of the training program. So it is a competency-based program, and those that have achieved those competencies, whether they achieve those competencies prior to getting a true training number, or whether they just go quicker to get those those competencies, they can move through the program quicker, and we would support that. Having trained some of my training in North America, although the time in years may be less, the time in hours may be slightly different. I think that would be a fair port of call. The trainees in Vancouver, when I trained, did a hell of a lot more than 48 hours a week, and that is for certain.
Well, for all the trainees and trainers listening, what can we all do going forward to improve the training experience based on this survey? A quick response from everybody, please. Richard.
So, I mean, I could name a million different policy changes that I'd like to make, but I think at the risk of sounding overly saccharine, I think just trainees and trainers go for a coffee together, talk to each other about your lives, develop closer relationships, because it's those close relationships that lead to better training and to better consultants of tomorrow.
I'm in absolute agreement with Richard. It's a more enjoyable day if we're working together. We're sometimes enjoying each other company outside the training environment, and I think actually that's how we get to know because in the end of the day, both Chris and I have now gone through 3 probably full cycles of trainees who have become colleagues, and so actually, of course, you're going to employ the people that you want to be surrounded by. One of the things that I would just really, really encourage is that you keep doing the survey and keep reacting to the survey year on year, looking for trends within the survey. Because if one thing that Chris and I can do for the SAC is we are your voice, although we are meant to be, delivering training, we're your voice to those that actually provide the funding for training. So we will do what we're told. So we want to know what that data is.
So I have a very simple thing. It's just everyone be dead on. And I think that'll just help stamp out a lot of the bad vibes and the bullying harassment. And then the second thing is maybe even rather than one block of 3 months, maybe we could do 2 weeks a year. I know in Yorkshire they do that. They go 2 weeks, they go off to do cleft, or they can go off to do aesthetics. So maybe that might be a way to get around the financial issues. So maybe 2 weeks a year, go off, and that would be more acceptable to the hospitals potentially. Those are my 2 things.
And I would say that I think at the beginning of every day you define exactly what each individual wants to get from that day, and make every interaction a positive one between trainer and trainee, so that everyone knows the rules of engagement as adult learners and teachers of adult learners.
Awesome. Thank you so much, everyone, for your time in joining us today to put this podcast together. We really, really appreciate it. I think our listeners are going to get a huge amount out of it, particularly obviously in the UK, but actually around the world, because a lot of what we've discussed is faced by every other training system in every other country and continent around the world who read JPRAS. So I hope everyone's taken something from that. Thank you very much indeed. James, that was a fantastic conversation and a lot of hot topics covered. What were your key takeaways, do you think?
Well, first of all, I think it was great to see that, the Plaster Committee is keen to do a survey for all the trainees around the country, and to see that our senior leadership in the educational sphere is very committed to providing the best training opportunities for residents up and down the country. I think one of the things that really struck me was the thoughts for giving people the opportunity to get the indicative numbers and the thoughts around out of program training during the residency, and about how you can potentially go to different deaneries and get those numbers that are more difficult to get. So I think that's really key to foster collaborative relationships between deaneries and to allow people access to the high volume centres for the different subspecialties. Yourself?
No, absolutely, and it was great to see senior leaders really engaged and using this paper as sort of levers for change. Interesting that some pockets of excellence are in different areas of the country, and perhaps, it seems like there's a lot of energy going into standardizing that and replicating best training like there is best care in different places. So I thought that was really good. I think we'll wrap it up there, and thanks everybody for listening to another episode.
Until next time,
the rest is plastics. Please like, subscribe, leave us a review, and submit your research to JPRAS.